I think I know most people here. My name is Miles. I'm one of the R1s, and I wanted to talk about angiomyolipomas today. Take a look at the evidence and see how that's affecting management and indications for management. Dr. David Liu from Interventional Radiology has been kind enough to come and share a couple slides a little later about the treatments that interventional radiology can offer. So I wanted to talk about epidemiology, etiology of AMLs, presentation, diagnosis, take a look at the natural history and how it's changing, how our understanding of the natural history has changed over the last 50, 20 years, and look at intervention options and intervention indications. So AMLs have two main clinical subtypes. There's sporadic and then there's the genetic. The genetic would be the tuberous sclerosis complex or lymphangioleiomyomatosis. Tuberous sclerosis can have LAM associated with it. It's quite common to be associated with tuberous sclerosis. So first I wanted to look at the epidemiology of spontaneous AMLs. This was a study that was performed just looking at AMLs that were found incidentally on abdominal imaging for various indications. And it looked at over 61,000 patients that had abdominal imaging. And it found an equal prevalence, it looked at basically equal number of men and women for about 13 years. And it found the incidence of AMLs to be about 0.44%. And this is higher than previously has been documented. Previous studies, whether cadaveric or screening ultrasound, have found it to be about 0.14 to 0.3%. So this is a little bit higher, but it's also a larger study that's equal in number to all the other studies combined. And it found a ratio of 3 to 1, female to male. Other studies have found between 2 and 4.5 to 1, so it's within keeping with that. If you take a look at the graphs, you can see that the AMLs increase in prevalence as people get older, and studies have found in the past that most people present with symptoms about 40 or 50 for sporadic AMLs, and it's younger for TSC complex, but we'll talk about that a little later. Looking at the individuals that become symptomatic, it also is the 40 to 50. Now, being that these are sporadic, it's been difficult finding what exactly makes them grow. This is a study that looked at hormone receptor expression in AMLs, and there previously has been documented studies looking at microarray analysis of renal parenchyma that showed no expression of estrogen receptor, androgen receptor, or progesterone receptor. So this study was retrospective. It was looking at the Mayo Clinic's nephrectomy registry over about 34 years. Found 110 patients that were had either partial nephrectomy or nephrectomy for AMLs. There was a predominance more to females. In this study, it was quite a bit more females, and that maybe is towards the natural history, being that females tend to possibly have larger AMLs. They found 56% of people were symptomatic. Now, being that this study looked at the expression of the receptors or expression of the estrogen, androgen, and progesterone receptors, and it found that 100% of AMLs had estrogen receptor positivity, and renal parenchyma or stroma has been shown to have 0. For the androgen receptor, 79% of the AMLs were positive for the androgen receptor, and the progesterone receptor, it was 38%. So this is a possible etiology for what helps grow and feed AMLs and allow them to become a problem as they get larger. And it also hints on why it's more predominant in females. In tuberous sclerosis complex, it's autosomal dominant, but there's also sporadic mutations that individuals are born with. There's about 1 in 6,000 to 10,000 births that are afflicted by TSC complex, and this mutation is either in the TSC1 or TSC2 genes, and what it essentially affects is the ability of this to form a heterodimer to inhibit the mTOR pathway. With the mTOR pathway being not inhibited, you get growth of multiple different tissue types, one obviously being angiomyolipomas. And with this uninhibited growth, patients grow multiple angiomyolipomas, they grow larger AMLs, and they're also more symptomatic. And this would account for about 20% of AMLs that would be seen in your office. Now, this is a study that looked at 209 patients who had had a partial nephrectomy or nephrectomy for AML, and not all of them, this is looking at after the fact, what's the pathology. So initially, there's 209 patients, and only 98 of them were suspected to be EMLs. But there was 119 patients that it was found to be AML after the fact. And this shows, or it importantly shows, the number of AMLs that are fat poor. Looking at imaging, that's always been a difficulty in deciphering if it's an AML or an RCC, and we'll talk about that a bit more later. But as you can see here, there's predominance for operating on AMLs that are fat poor. Most of that's the confusion with RCC and the concern for malignancy. And if you look at the number of patients who were treated, there was 94 that are classic. But looking at the pathology, there's three main pathologic subtypes. There's the triphasic classic, so that would have relatively equal parts of smooth muscle, of vessel, and of fat. There's also monophasic, so 95% of one subtype, and then the epithelioid variant, which is something I won't go into this talk because it's a small subtype that can be aggressive. Now, they also did find some concomitant RCC with AML. It's not very common, but normally the surgery would be identical. You want to take it all out anyways. Now, looking at the clinical manifestations, patients can present with flank pain, palpable mass, hematuria, internal hemorrhage. That can either be from the parenchyma or from aneurysmal vessel rupture, or there can be retroperitoneal hemorrhage, and that's called Wunderlich syndrome. There was one study by Ozit et al. That found that retroperitoneal hemorrhage was about 17% in his population. They found flank pain in patients that were operated on was about 30-40%. So the most common indication for operation was flank pain. Palpable mass, 11 to 30%. Hematuria, 11 to 20%. So it's fairly predominant number of individuals that are symptomatic come from flank pain or palpable mass, hematuria. Looking at the imaging of AMLs, the main modalities would be ultrasound, CT, and MRI. Ultrasound, there's a significant overlap with RCCs. About 12% generally for renal AMLs larger than 3 centimeters. There could be confusion with an RCC. And when you're looking at masses that are less than 3 centimeters, it can be about 20 to 30%. So it's not very sensitive or specific. Typically, there'd be strongly hyperreflective lesions with acoustic shadowing. That's the classic findings. There are other findings as well that can help, but once again, there's a high degree of overlap between seeing that in an RCC and seeing that in an AML. CT is the mainstay. It's the workhorse of imaging for AMLs. About 45% are unable to detect the intratumoral fat. And as we talked about, that's the difficulty. Those would be the fat poor AMLs that CT would be unable to differentiate from RCCs. Classically, AMLs are hyperattenuating, homogeneous enhancing masses with prolonged enhancement. And some studies, the newer studies I was reading, show that the prolonged enhancement is a good indicator of an AML. Now, MRI has become more prevalent, and especially down in the States, there's a lot more imaging done with MRI, so there's been work into if we can differentiate more AMLs from RCCs using MRI. And on chemical shift MRI, T1 weighted and T2 weighted, there has been some work that has improved the specificity, unfortunately not the sensitivity, from the studies that I looked at. Looking at the main findings, they discuss an India ink artifact. Now this is an MRI study. It's looking at AMLs. Well, this is looking at possible AML. So in group 1, there were a greater than 50% chance on CT scan that would be an AML, or that would be an RCC. In group 2, it would be about equal to 50% chance that it's an RCC or an AML. And in group 3, the thought would be most likely it's a benign lesion, less than 50% chance that it's an RCC. And if you look in group 1, that was the group that there's a greater than 50% chance that it's an RCC. There was lots of AMLs, there's lots of oncocytomas, and complicated cysts, and all that was confirmed pathologically after. So MRI here has helped delineate the lesion. So when they looked at the numbers, they found that of the 103 patients diagnosed with RCC by CT, that 26 of them were diagnosed as having a benign lesion on MRI. So that's 26 people that either could be watched or wouldn't need an intervention, wouldn't need surgery. And looking at patients who were diagnosed as having a benign mass, someone that you might say this is small, we don't need to do anything. 5 patients were diagnosed with RCC by MRI. So that's 5 people that could have a surgery that could be curative for a disease that they thought was benign on CT, which might be the only image we'd order here. Now treatment, in the past, many studies say that if there's query of a lesion, you have to cut it out. And obviously things have changed over the years, and as our imaging has got better, and as our understanding of what an AML is in the natural history, there's been more, well, there's been some masses that don't require surveillance. There's been active surveillance. There's been new treatments for medical management. Also nephron-sparing approaches, so partial nephrectomies, and then interventional radiology approaches, embolization, RFA, cryo, microwave ablation, and radical nephrectomy. So this is a cohort, it's retrospective. It was at the Cleveland Clinic, 400 patients, looking at a database with a final diagnosis of renal mass. So this would include all the renal masses. And then they looked at a subgroup looking for fat in the lesion. So once again, this would include fat-poor AMLs because that wouldn't be picked up on a CT scan. And there was 400 patients. 270 were initially treated, and 130 were put into an active surveillance group. 10 of them had tuberous sclerosis complex. Now, 17 of these 130 patients that were put into an active surveillance group required delayed treatment. The patients were followed up with examinations and imaging at 6 months, 12 months, and then annually after that. Now, looking at this group, the patients that were symptomatic and had interventions initially, 35% were due to flank pain, 23% were due to increased growth, 17% were due to hemorrhage, 17% just patient preference, and about 6% for hematuria. The study, that's of the 17 that were intervened on after. Now, looking at this group, you can see that looking at the tumors, so this is of patients who ended up having an intervention and that have been outlined here. And if you look at the tumor size, less than 4 centimeters, very few required interventions. So possibly indicating that of tumors less than 4 centimeters, it's more benign in terms of growth rate, flank pain, patients being symptomatic. Greater than 4 centimeters, it was statistically significant that more patients required intervention. And also in terms of intervention and requiring intervention later, there was a higher incidence with patients who were symptomatic at presentation. So size greater than 4 centimeters and symptomatic presentation were found to be statistically significant for discontinuation of active surveillance. These are the curves looking at the masses in terms of how quickly they required an intervention. So the blue line shows less than 4 centimeters, and most of them stay stable, don't require an intervention. And greater than 4 centimeters, there's progression of intervention, largely at about 1 year, but also as quite a few years post that. And looking at symptoms, it's just a steady increase in intervention rates. Now, this was a retrospective study looking at AMLs identified by CT, and once again, they're identified by fat component. They were also analyzed by pathology after. Looked at 254 patients, and 129 were treated. Now, if you look over at the box that's been highlighted, there was mostly asymptomatic patients. So previously studies saying 30–50% of patients are symptomatic and require treatment. Newer studies have been showing less patients are symptomatic, less patients are going to require treatment. Once again, flank pain, gross hematuria, and they even included fatigue. They didn't really describe what they thought the etiology was there, if it was anemia or some other cause. And spontaneous rupture. And here, spontaneous rupture, it's only 2 patients, 6%. So the other study is showing 17, a concerning number for a spontaneous hemorrhage, maybe making people be a bit more aggressive, is quite less frequent as previously thought. Now, if you look at the age, once again, 40, 50 is the common age for people to be symptomatic. Mean tumor size in individuals that are sporadic was about 3.7, so smaller. Looking at patients with tuberous sclerosis, 7.6, and as previously indicated, tuberous sclerosis generally has larger lesions that grow quicker. And symptomatic presentation showed to be that there was more interventions if there was multiple tumors or if they were bilateral. Now, looking at the treatment, so those who are symptomatic, once again related to tumor size. So less than 4 centimeters, very few patients required an intervention, and greater than 4 centimeters, statistically significant number of individuals did require an intervention. Here they're showing a larger number of individuals getting nephron-sparing surgery, and that's been obviously the trend since partial nephrectomy has been a viable option. But there's also been an increase in embolization. So this is a new study. It's by Bott et al. It was in European Urology this year, and it's retrospective. It's looking at patients from 2002 to 2013, and these are patients that underwent abdominal imaging for any reason. AMLs identified by the report, and it looked at fat and lesions, once again not including fat-poor AMLs, and identified 2,741 patients, and of those patients, 447 patients were followed, which means they had more than, they had 3 sets of imaging within at least 1 year. Now, it's too bad that the other patients didn't have imaging, because this would have been an extremely large study to look at the natural history in a more broad way. Now, of the patients who were followed, for TSC status, which is important as we know because it predicts size, predicts growth rate, and predicts age of presentation, which are all important, it found that those things are all important for if they're going to require management. So TSC status, clinical presentation, so if they're symptomatic, and lesion size. Looking at the patients who weren't followed, who only had the one imaging, the one image, they did actually look at how many patients required intervention. And of those patients, only 0.56 required intervention. So of patients who weren't actively followed, less patients had interventions. Less patients were either presented symptomatic or had individuals who were watching their care say, we need to do something. I think that's pretty powerful, being that the people obviously didn't think there was a problem, or if they did, when they finally presented, it was such a low number of individuals. In the group, retroperitoneal hemorrhage was only 0.4%. So studies saying previously 15% of individuals had hemorrhage and required intervention. This study, the largest one by far, only had 0.4%, lending more to the benign nature of the disease and the need for fewer interventions. This shows the growth rates, And now this is greater than 4 centimeters and less than 4 centimeters. And it's showing that there's equal growth rates. So of the individuals who have larger tumors, not necessarily do all of them grow quicker. And they only actually found that 10% grew at a quicker rate. So this is a study that looked at intratumoral aneurysms and looking at the formation and the rupture. So it was retrospective, small number of patients, 23, and all the patients had to have CT scan and angiography. Now looking at this, if you look at the number of individuals that had a rupture, most of them were larger than 4 centimeters. But if you look at the ones that had the aneurysms, it's aneurysms that were greater than 5 millimeters that actually correlated, that had higher specificity for rupture. Though 4 centimeters classically are the lesions you're concerned about, it's sensitive, it's not specific. So many of them greater than 4 centimeters won't have any rupture or any problem. But of the individuals that had aneurysms greater than 5 millimeters, there was a clinically significant number that had ruptures. So it's a more specific indicator of a patient that may get into trouble. And if you look here at the size curve, let's see if I can, it's not showing, oh there we go. So this is showing the relationship between tumor size and aneurysm size, showing that larger lesions do have a tendency to have larger aneurysms, and maybe that's the reason that some of these larger lesions actually do cause problem. It's not simply just the size of lesion. This could give us something to look at for patients that you're monitoring who have maybe lesions that are 5, 6, 7, 15 centimeters for when do we actually need to do something.
So Miles,
yeah.
That's an aneurysm within the AML.
That's correct.
So maybe, I don't know if you're about to answer this then. Is that normally reported when we talk about this? Or do you
So on CT scans, they're actually, they're not sensitive enough to usually pick these up. So it would be on angiography, but
yeah. Part of the issue is that with actually the Yamamoto paper was a classic one in 2002, and the resolution because of the technology only allowed for a maximum axial or a thinnest axial diameter of about thickness of about 5 millimeters. 5 millimeters is the lowest threshold of detection. But if we do protocols like the CTA protocols or renal transplant protocols, our axial images get down below 1 millimeter. So we don't really know where we lie in that receiver operating curve because the technology has advanced so much. But certainly what we look for is if we do see evidence of an aneurysm, that's a predictor of potential for rupture. Although obviously the size has been classically the second one. But most community radiologists, most community protocols are typically between 3 to 5 millimeters in diameter in axial section, and therefore potentially below the threshold of detection.
And it's going to be during the CTA phase of the CT.
Yeah,
pretty much.
has to be. If you do the renal donor protocol, yes. If we protocol it as a GIG protocol, which is what we do usually in a suspected rupture AML, yes. But obviously, if there's active extravasation or including contrast, it's very difficult to identify.
What would be a Mannas protocol?
No. But those are things that can be clarified. The downside is of the competing technology now is that we're decreasing radiation dose, so it just increases what we call quantum model. But if you just want to identify a single aneurysm vessel in a slice with the same data set, you can use it just looks fuzzy. It's not diagnostic for a tissue, but it's potentially diagnostic for morphology. So those could be potentially changes in protocol if you're interested.
It's not just that one single aneurysm. It's more of a count of the whole number of aneurysms. And that's what we always see with the larger ones. We always count.
Yeah, the biggest one in the multiplicity. The multiplicity is kind of more of an indication of internal, tumoral biological schmutz, and the largest one, as with any vascular structure, increases the risk of rupture just due to the
Thank you. So this was actually another study looking at the AMLs and microaneurysms. It's retrospective. It's a French study. Looked at over about 10 years, patients who had CT imaging, 31 patients with a total of 54 AMLs had CT imaging followed by renal artery embolization due to hemorrhage. And it wanted to look at the size and how many actually had microaneurysms. I guess as you're saying, this study's a bit old, so probably the imaging couldn't pick up anything less than 4 centimeters, like smaller microaneurysms. But this study showed that in AMLs that are less than 4 centimeters, none of them they were able to pick up any microaneurysms. And all of the aneurysms were found in lesions that were greater than 4 centimeters. Once again, showing that lesions that are less than 4 centimeters will probably grow slowly. They probably don't have any microaneurysms and will never cause anyone problems. So looking at the treatment, there's been innovations in medical therapy, also interventional techniques, and surgical techniques. So this is a study looking at Everolimus. It's an mTOR inhibitor, and this is the EXIST-2 trial. It's multi-centered, RCT, double-blinded, placebo-controlled, and it was looking at the effectiveness of Everolimus. And it was assigned 2 to 1, so they wanted to obviously get enough patients in the trial. TSC is a fairly rare disease, and you want enough individuals who are getting the therapy. There was also a systematic review that was published by the same group looking at all of the non-randomized trials, but it has essentially the same outcome. Now, this is looking at the response rates of patients on placebo versus Everolimus, and this is showing that individuals who got the therapy had an average decrease in size of approximately 60% of their tumoral size. That individuals who had placebo therapy, none of them had more than a 50% decrease, so it's not spontaneous. And there was a significant decrease, and it was independent of sex and if they're on anti-epileptic drugs. Many are for TSC, and each one of those represents an individual patient. So as you can see, there was quite a decline in the size compared to placebo control. And they used the best percentage decline. They were looking at the diameter and then estimating the volume.
Is that only renal or other lesions?
Yeah, this was just renal.
Because these oftentimes will have
Liver and other involvement.
brain.
Yeah.
They capture, because renal cell tends to be loss of, kidney lesions that have more LOH or loss of zygosity, which makes them more dependent on this pathway. Is there evidence that other lesions respond to brain and liver?
So there were other papers. I didn't actually review them to look at the response.
One was later, because sarcomas of the brain. There was a RAM study, which was also get lymphangiomatosis.
Yeah.
So both have very strong reduction.
This was a study looking at Sirolimus, so a relative of Everolimus, looking for the effect. Once again, it's prospective, multi-center, phase 2, looking at the safety, also looking for effect. And it was patients 18 to 65. 1 AML need to be at least 2 centimeters, which usually isn't a problem for these patients. They form many and they form large. And at baseline, the AMLs were visualized by abdo-MR. Now, as you can see here from this graph, there was a significant decrease in the size, and most of the patients were evaluated over 24 months, and 21 of the 23 lesions were smaller, so most people did respond to this therapy, and most had a partial response that was sustained over at least over the 24 months. So showing that it's effective, but also it's maintained.
After stopping the drug?
No, continue on the drug. Yeah, 2 years of individuals on the drug. This it requires continuous inhibition. I'd like to invite Dr. Liu to a few words.
I think that was actually a great overview from a radiologist perspective as well, because the biological mechanisms are something that we don't get exposed a lot to. Typically, we do an MR to look for in-phase, out-of-phase EMA-Inc artifact. But as you all know, there's an inherent limitation to the spatial resolution of MR, so detection of things like microaneurysms or subtleties within the tissue itself can sometimes be difficult, especially if patients have had previous bleeds because of the hemosiderin staining affecting the ability to image effectively. So we're stuck in a quagmire too. The CT will give us better resolution, and the MR will give us a kind of chemical constituency. And in many instances, because of the lipid poor population or the fat poor population of AMLs, we're kind of stuck in the middle as well. So it's kind of a classic radiology lesion, which is one that we kind of have to hedge on and not necessarily come to a hard decision on. Now, as an interventional radiologist, I of course see these things in a slightly different way. Miles was kind enough to invite us to go over kind of some of the basic techniques and the approaches that we use for embolization, and also touch base or give you an update on some of the current literature regarding ablation in AMLs as well. So, as we're all aware, 3 o'clock in the morning or on Friday at 3 o'clock in the afternoon, the treatment of choice for a bleeding or ruptured AML is embolization. Basically, what we need to do is create or facilitate the patient's hemodynamic stability, and then secondarily provide some sort of devascularization of the AML, although it's kind of arguable as to whether we're successful in cytoreduction. The rationale, as I mentioned, is really to decrease vascularity and create secondary ischemic effects on the parenchyma, which the bitter irony of it is that usually in the acute setting, when we're doing the embolization, the vessels are in spasm. So when we do the embolization, we do control the pressure temporarily. But as the vessels become less spasmodic, as the thrombus begins to clear, the tumor then has a tendency to revascularize in a hypoxemic state. So therefore, you actually potentially can get upregulation of the vasculature through VEGF pathways. So we want to do something where we don't interfere with other treatments, specifically destination therapy, such as surgical resection. And when we do the embolization, there's no real size limitation, and the anatomy generally doesn't matter. But of course, we try and spare as much of the parenchyma as possible. And this is a minimally invasive technique that's widely available through most interventional radiology departments. So if we take a look at the largest meta-analysis to date, this was by Murray, actually last year in Journal Urology, and essentially demonstrating that AML embolization is relatively well tolerated. Post-embolization syndrome in a third of patients, I would argue it's actually probably a little bit higher. When we perform an embolization, all the cytokines actually get released as a result of the embolization. Of course, the edema and bruising can cause flank pain, and there can be some transient hematuria, but that may be part of the same presentation of the ruptured AML to begin with. Complications are about 7%. Those complications would be considered relatively uneventful. Growing hematomas, typically potentially renal compromise in patients who are renal compromised, and no deaths, with unfortunately a planned incidence of re-intervention of about a fifth of patients. So a fifth of patients will either have to come back for another embolization or will have to come back for surgery. So this is the typical requisition that we get at VGH or UBC. Right upper quadrant, right lateral flank pain, urine, blood in urine, likely urolithiasis, choreocyzin locations. This is a de novo presentation. And this is kind of where you actually see abdominal radiologists kind of hop off their seat when they see this, and then say, oh, come on over here, take a look at this. And as we can see, this is kind of a very classic presentation, retroperitoneal bleed. As we can see here, the kidney itself being displaced, and just a little lentiform subcapsular hematoma. So this is with contrast. Now we can see the active extravasation here. We can see the kidney is deformed as a result of the mass effect. This is just tip of liver, so that's not active extravasation, but we can see the stranding in the retroperitoneum and also encapsulated, and also the encapsulated hematoma, as I was alluding to earlier.
And how often do you see a break outside of Tuberous?
Pardon? You know, it has to be pretty big.
Yeah.
Not very often. This one was a little bit more of a dramatic presentation, but usually it's restricted. Usually we see it fairly well delineated. So this is kind of the classic angiographic appearance. So this is a catheter placed in the common femoral artery. Oops, a bit of touch mouse. Reverse curved catheter selected where the arrow is, and then we can see the renal arteries coming through. And here's kind of. And here, this early blush where that arrow is the representation of the ruptured portion or the aneurysmal portion. Super selective catheterization, you can see that there's the aneurysm. You can see active extravasation. Gee whiz. This mouse isn't really working too well. It's pad. Okay, so you can see the active extravasation. Let's see. The active extravasation here. And then you can see the ruptured vessel there. And then we can see a coil placed right here where the aneurysm is, and then selective embolization. Now, one thing that's important to note is that oftentimes we don't see a single infeeding vessel into the AML itself. Oftentimes there are multiple branches. And as a result of that, in spite of the fact that we're trying to spare as much of the liver parenchyma as possible, inevitably there's going to be some collateral damage. So in the ideal situation, that one presented in 2010, You can see the slow maturation of the AML, still very rich in fat. You can see the coil fairly well defined and the trajectory of 2012 to 2014. And one could argue that you're actually already starting to see the evolution of the revascularization, because you can see more intermediate attenuation tissue within the arterial phase as compared to 2012, where it was completely fat. So even in a situation where we're successful in stabilizing the hematuria, where the tumor has a tendency, or the tumor involutes, we actually see on radiographically the evolution and reestablishment of the vasculature, and therefore we know that we're not definitive in cytoreduction or tumor control. So the rationale behind potentially marrying ablation in with management of AML is very similar to the surgical axioms, and of course is meant to be a complement as opposed to a competition to nephron-sparing surgery. The stakes for this are different than in RCC management. We're not about complete annihilation of tissue with collateral damage. What we really want to do is A, destroy the blood vessels to decrease the bleeding risk, and B, destroy the parenchyma, in other words, take on a cytoreductive strategy so that not only the tendency to revascularize, but also the vulnerable and aberrant tissue may be under control without having to be overly aggressive in therapy. The percutaneous option obviously avoids surgery, especially in those patients that may be of surgical risk. That may be a consideration. And it's not for all patients, because at this point we're limited by the modulation and flux of energy that we can deposit into the tumors themselves. Cryoablation, RF, and microwave have all been tried with success. The studies are very small, as you can see, basically just an N of less than 15, with technical success rates of 80 to 100%. Now, there are different ablative strategies, and none of them has been demonstrated to be clearly superior, but if we go into the physics of the way that heat is generated, or cold in the case of cryoablation, the one technical winner is actually microwave. The reason for that is because AMLs, especially those ones that have a high content of fat, cannot really receive a lot of electron flux. And with radiofrequency ablation, you need electrons rubbing back and forth to create the friction. While in microwave, all you need are protons, so you can actually generate heat much faster and also in a larger area. So the largest experience to date with microwave AML is actually the University of Wisconsin, and it was in 11 patients. Mean diameter relatively small, 3.4 centimeters. The largest one, I believe, was 6.2. 2 patients that had failed embolization, all using hydrodissection. 2 reasons for that. One is to minimize collateral damage to other vital organs. And secondarily, the theory was that by using hydrodissection, it would actually maintain the capsule so that in case future surgical intervention was required, that it would have less scar tissue in the recovery period. No complications, no bleeds, demonstrating a volume decrease of about 44%. If we do an embolization on a tumor, on an AML, typically our volume reduction is about 20%, because we're not really cytoreducing the fat content. As we all know, fat doesn't need a lot of blood vessels to maintain itself, so therefore that component of it is preserved. So here's an example of a 2-antenna microwave ablation. As you can see here, hydrodissection with a little bit of dilute contrast, two microwave antennae in place, post-gas formation, ultrasound demonstrating hydrodissection and also the post-ablation zone. And here's the evolution of this type of procedure. You can see pre-embolization, in this case with the hydrodissection in place, coronal plane, nice aneurysm defined here. This is a post, and typically a post-embolization would look something like this. So this is the patient that was treated with an embolization, has a post-embolization, and ultimately 1 year post-microwave, you can see that's completely devascularized with no fat in it. And I have to correct myself, this was actually a patient who presented with a presentation of bleed and treatment. So this was actually presenting bleed. And once again, you can see the aneurysm there quite nicely. And these are the types of isovoxel type coronal reconstructions that we can do with the proper CT protocols.
So Dave, if you look at the middle one, the middle one is really close there.
Yeah, that's the post-embolization, but what you can do is you put a needle down into it and then you inject D5W. Yeah, so it pushes everything out of the way. And that's why we need ultrasound and CT to be able to perform these procedures. Here's another one with a very broad base. You can see that here is the feeding vessel. So on the ablation intent to treat, generally you look for the arterial phase and look for the bleeding vessels and try and skewer them and burn them. With microwave, you can burn so hot and so intensely that you can pretty much cauterize the vessel, thermally cauterize. So here's a successful versus a non-successful. So here's pre-ablation and post-ablation, untreated and treated. So what we can actually see here is that over the course, this AML has now encapsulated, although there's a little bit of intermediate attenuation. You can see that it's well encapsulated and has really kind of retracted into the capsule. And here's one that has technically failed. So as you can see, the morphology of it really hasn't really changed very much. So we can obviously monitor the results of these through the standard active surveillance mechanisms. So Miles, back to you. So those are some of the things that we can do. Certainly, as I've spoken with many of you, I think that there may be an opportunity for us to explore ablations with AMLs, but sorry, Alan. Pardon me? Well, I think nobody really knows, so people are fairly conservative at this point, generally taking it up to about 4.5 to 5 centimeters. Because AML is different than RCC, we're not really worried about margin so much as getting the pedicle. But I think it's a case-by-case basis. You know, if it really has a very narrow claw or pedicle, as long as we devascularize that base, that's ultimately all we're really looking for. But microwave definitely has a potential to take the lesions larger. We've just never really tested those waters, and it hasn't really been published yet. It's too early in the research cycle.
What's the potential for bleeding when you do cutaneous ablation?
Relatively low. I mean, it's about the same risk as when we do our RCC ablations, because essentially it's pretty much the same type of procedure. One could argue that the risk of bleeding with an RCC is higher because it's much more vascular. But ultimately, you know, I feel we could probably do this on an outpatient basis and with low risk.
What would you prefer to have? Would you prefer to do
Well, I guess it all depends on the size. Once you get above a certain size, like I would say comfortably above 6 centimeters, I don't think we would be doing good for the patient by approaching with an ablation, especially if the patient's not stable. Obviously, having vascular access is something that's good in those situations. But I think anything less than 5 centimeters that is not considered a surgical candidate would potentially be fair game. Especially those patients with bled-out AMLs, it may also be a fair consideration because it's probably going to be a dog's breakfast going into operating those anyways. So even if we do cause scarring as a result of the microwave, you can blame the bleed and blame us after.
All right, thank you. So next I wanted to look at surgical interventions. This is a study that looked at benign disease, looking at radical nephrectomy versus partial nephrectomy. It's retrospective, about 500 patients, equal number of men and women. And in terms of the pathology, about 58% oncocytoma, 24 AML, and 11 cystic disease, 8 kind of a hodgepodge. So not all AMLs, but benign, so it doesn't include RCCs. And it's looking at the overall survival with nephron sparing versus radical. And the median age of patients was 63, and the range was 13 to 92. And this study showed a 2.2-fold increase in death from any cause on multivariate analysis with radical nephrectomy instead of nephron sparing approach. They also found univariate statistically significant results with change in GFR and eGFR after, but not on multivariate analysis. Now this is a study that at least one person in this room will recognize. This is published by Dr. So. It's treatment of AMLs from here, and it's looking at kind of from our center what's been done. So it looked at a period of 10 years. Dr. So went back, or maybe Dr. Fadigan, I'm not too sure, but and looked at the number of surgeries versus angioembolization, and looking at what we've preferred to do for what kind of case. So there's been more surgeries for AMLs. It's about equal. It's more females, which you would expect. But if you look at multifocal disease, it's been more commonly angioembolization that's been done. Makes sense. If you're really trying to spare nephron, these people might need multiple surgeries. There's a higher number of people with TSC that have multifocal disease. With acute hemorrhage, more often angioembolization. Part of that's probably access to OR and other things. But if you look at surgery, one shot does it all. So you're not looking at multiple interventions. And Dr. So published this and also said, more research needs to be done to look at, when we should be operating and what's the best technique for each different indication, because there's lots of different indications to operate. So just to kind of wrap up, looking at indications, so obviously Wunderlich syndromes, no one's going to argue that you need to intervene for that. There's internal hemorrhage that's probably showing instability of the tumor, aneurysm size has been shown to be both sensitive and specific for requiring intervention because it's high risk for hemorrhage. Always for suspicion of malignancy, so the fat poor AMLs are either going to get biopsied and maybe get a treatment depending. If the patient's symptomatic, though I think a lot of that's changing. I think the numbers that I've shown here are showing that less patients are truly symptomatic from AMLs and less patients are going to require treatment for that. Looking at the size, less than 4 centimeters, these masses grow very slowly. They usually don't have any internal aneurysms. So unless there's other risk factors like individuals who are young at reproductive age or they have TSC and multifocal, they probably don't need even to be followed up. Multiplicity, so if there's lots of tumors, it shows that there's an inherent tendency to growth. The epithelioid variant, which I didn't talk about. In terms of the young female of reproductive age, I think it has to do with the sporadic nature and the paper that I showed that showed the presence of estrogen, progesterone, and androgen receptors. And there's only been about 35 case reports of hemorrhage in pregnancy, but it's obviously important because it's life and death for the mom and also for the fetus. But once again, there's actually not a lot of evidence that the tumors grow quicker. There's actually no studies that look at the size that's growing of the AML through the pregnancy. It's just thought that they grow quicker and that's why they rupture. Also, other things to consider in a situation like ours is limited access to emergency care. So people who are maybe up north, some of Dr. Patterson's homies, as he called them, which does he need to intervene on? If they're going to require long-term anticoagulation, looking at the growth rates, people intervene for growth rate, but there hasn't been actually studies looking at the growth rates in microaneurysms and maybe the patient age as well. So just to wrap up, AMLs are uncommon, but they're not rare. They can present as a diagnostic dilemma. Imaging is imperfect to delineate them from RCCs. I think the natural history has changed over the last 20, 40 years. And also our understanding of which needs to be followed and which we actually don't need to follow. Looking at the studies that I presented, I think less than 4 centimeters that don't have any internal aneurysm, patients who aren't young in age of pregnancy, they probably don't need to be followed. And previously, they all have been followed and advocated that they need to be followed on an annual basis. But once again, there's no guidelines, and I think that would be quite useful, being that this is a fairly common thing to be seen that can have drastic implications. And the treatment's obviously changing and need to have indications which treatment's best and when treatment's indicated. That's it. Thank you.